what about, we talked a lot about the idea of curing patients with locally advanced head and neck cancer. Is there a role for immunotherapy in that setting?
I hope so. I don't know yet. So let's talk about what we do know. So at ASCO, we saw safety data from Keynote 412 that showed us that it is safe to combine pembrolizumab with chemoradiotherapy. Efficacy-wise, it will be a long time before we have hints at that. I have an ongoing trial with collaborators looking at pembrolizumab alone with radiation therapy for patients for whom cisplatin is indicated, but there's some contraindication like high-frequency hearing loss or tinnitus. Others are doing similar work, and I think in the next year we're going to get a flurry of safety data on the combinations of immunotherapy and radiation that will then empower efficacy design studies to say, how should we do this? Should it be in combination with platinum and radiation? Should it be a single agent in which patients? The other place that I think that this can be evaluated is in an adjuvant or neoadjuvant fashion. We have a trial that is soon to open within a few weeks, combining carboplatin, nab-paclitaxel, and durvalumab preoperatively for locally advanced patients, with the advantage that biologically we'll be able to capture pre and post-treatment tissue and do all kinds of comparisons as well, blood along the way. And Josh, I know you have a related effort in the adjuvant setting.
That's right. So working with Tanguy Seiwert at the University of Chicago, we have a multi-site investigator-initiated study that's looking at patients who are at very high risk for recurrence. So taking patients who have N2B, N3 lymphadenopathy, oligometastatic disease, the patients who after chemoradiotherapy are saying, gosh, there's at least a 50% chance that this person is going to recur. And those patients are randomized to either immunotherapy with pembrolizumab or placebo for a year. Now, no one gets excited about including a placebo here, but remember, these patients are generally watched, and we don't give them a therapy. We just sort of sit on our hands and get a little scared. And so this gives the opportunity to incorporate an immunotherapy earlier. And in this minimal residual disease state, other immunotherapeutics from the hematologic malignancy world, there's reason to think that immunotherapy may be more effective when there's not a huge amount of tumor right there. And so it's a really neat niche where we'll be able to incorporate immunotherapy.
Yeah, I think we're certainly going to see a lot more data in patients with locally advanced disease. Jared, you alluded to some neoadjuvant data that was also presented at this year's ASCO, mostly to look at biomarkers around pembrolizumab responsiveness, but at least the idea that one could give a dose of pembrolizumab safely, and the intriguing thought that they may actually have an effect on the tumor. Of course, that has to play out, and the data have to mature. With all of those things in mind, we do now have a few ongoing phase 3 trials looking at immunotherapy in the context of chemotherapy radiation and also cetuximab radiation.